So we're going to have a set of fairly short presentations, 10 to 15 minutes each, no longer than that. And then there'll be definitely time, and that's what we welcome really with these events. It's not just about us kind of regurgitating what we've found, but also we want to engage in dialogue and discussion and opportunities for any questions as well. We're thinking it's going to run for about an hour and a half. We have 2 hours in the booking, but we think probably that will be plenty. We're going to be recording the presentations only. The recording has started, but we're going to turn that off when we do the Q&A session as well. So usual kind of online ground rules is just people could mute themselves during the actual presentation just to avoid any background noise as well. But please do put your cameras on for the discussion. You're more than welcome to do that. And just a little bit about safety and comfort. So we will be discussing issues around the experience of service use following a sexual assault. We won't be talking about, our research wasn't about the experience of sexual assault per se. However, we will be talking about levels of distress experienced by this group and how best to help. So that's the kind of areas we will be talking about. We'll be talking about a range of different kinds of mental health and substance use issues, including risk of suicide, self-harm, and intimate partner violence may come up as well. And we also acknowledge that many people, it doesn't matter what your background is or your professional background, have experienced these issues or work in the field with people who have experienced these issues. And we recognise this can generate some internal discomfort or distress. So please look after your well-being. Be aware of how you're feeling. If you need to leave and take a break at any time, you can, and rejoin when you want to. That's not a problem. People can come and go, and Andre will let you back in as fit. And also after the webinar, just consider what you can do for yourself in terms of self-care as well. And that's for all of us. That's not just for people who identify as survivors. That's a kind of a plea to everybody. And we also have a website, and within that website, I've linked some resources for organisations that operate services related to this topic as well. So that's the website there. It's, if you just Google MEMOS study and then go to the help tab, you can find organisations provide support. So, oh no, that's not, hang on a minute. Right, okay. So I just have to do a disclaimer. This is was funded by the NIHR Health Service and Delivery Research, and the views expressed are those of the authors, not necessarily those of the NIHR as well. Okay, just a bit of background just before we kick off. Sexual assault referral centres are integrated services that provide a bespoke place to address the needs of those who've experienced a sexual assault, usually by combining the forensic exam with addressing other healthcare and support needs. And this can include a range of things, STI testing, pregnancy testing, post-exposure prophylaxis for HIV, referrals to further healthcare and counselling, either in-house or external agencies. In England, these are known as SARCs, and they're commissioned centrally by NHS England at the Department of Health and Social Care, and they're delivered by a range of providers such as the NHS private healthcare and private security services and the police. Their offer is driven by NHS SARC service specifications. Research has shown that sexual violence impacts significantly on physical and mental health, and also many people who present have had prior treatment in mental health. But despite this, there's limited specific guidance on what role the SARC plays in assessment of mental health and substance use, as well as how care pathways should best operate. There's also a limited range of ways in which SARCs assess and respond to mental health as well. So the MEMOS study is was a three-year funded study. It actually got slightly extended because of COVID, but we'll talk a bit more about that, with NHS ethical approval. And we really wanted to understand and generate program theories, which is kind of just understanding the ways in which things work when they work well and for whom as well. And Steve Aris's presentation will talk a little bit about the realist approach that we took and some of the synthesis that produced those program theories as well. This included a review of the literature, an audit of SARCs, a screening study to look at levels of need, case studies of 6 SARCs, which included a range of things, including documentary analysis, interviews and focus groups with staff, those who attended and partner agencies. And then finally, we did a secondary data analysis with data from the South London Maudsley and the Kent SARC from the in-house therapy service as well. So the running order is as follows. Faye Maxted, who's the Chief Executive of Survivors Trust, will say a few words at the start, and then we've got a running order. We'll tell you a little bit about each of those work packages. So we've got Dora doing the systematic review, and then Bryn will be talking about the SARC survey, which was the audit, national audit. We've got a recording of Steve Arris doing the realist synthesis presentation, and then I'll pick up the last two, which is the case study qualitative analysis, the main findings from that, and finally the quantitative data, which is from the prevalence screening data that we got, and also the routine data analysis as well. And just to say, the report should be published almost imminently. The proofs have been signed off, so I'm hoping the full NIHR report will be in the public domain as soon as possible. So I'll say something about how you can find out how to access the report at the end of the presentations as well. Okay.